Hello, my name is Scott Luhmann. I am a professor of pediatric orthopedics, Department of Orthopedic Surgery at Washington University. I'm going to be talking today with Dr. Brian Kelly, an assistant professor in the Department of Orthopedics and Neurological Surgery, about scoliosis. Our focus today will be talking about scoliosis in children and adolescents. We welcome audience participation, so if you'd like to send us a question through the chat, please feel free. So I thought we'd just jump right into this overall and kind of lay some groundwork for what we're going to be talking about, and that's basically scoliosis. So Brian, can you tell us a little bit about what is scoliosis?
Great. Thank you, Scott. Glad to be joining everyone this afternoon. So scoliosis refers to a sideways curve in the spine. We know that some curves are normal in the spine, that a little bit of asymmetry can occur normally. And when we look at people from the side, we're used to seeing some roundness to the posture and a sway back. But scoliosis specifically refers to those sideways curves. And we can think about the magnitude or the severity of the scoliosis and quantify that by measuring what we call a Cob angle. And just by definition, we call scoliosis any curve that we can measure more than 10 degrees. Like I said, that kind of little bit of asymmetry is a pretty typical thing.
Okay, so we're talking mainly about today children and adolescents. Why do we see so much more of it? Why does it happen in kids that kids appear to be fairly normal appearing when they're growing up in their young ages, and all of a sudden things start to get out of alignment?
So we know that there are a bunch of different reasons that scoliosis can happen, but generally scoliosis and its progression is related to growth. So we know that when children are growing and growing rapidly, curves are at their highest risk for appearing and getting worse. So we can see scoliosis appear and progress during any point of growth, but adolescents in particular tend to be at higher risk when they reach their adolescent growth spurt and when they reach puberty. And it's the growth that is one of the main driving factors of the progression of scoliosis. So we tend to see children appearing in our clinics sometime most commonly between age 10 and 12 for girls, and a little bit later for boys, as they tend to hit that growth spurt a little bit later on. When you see these kids, Scott, at this age, coming in to be evaluated for scoliosis, what brings them to your clinic? What do you evaluate for? What do you tell the parents about?
If you focus on the adolescents that you just brought up, they come in for various asymmetry problems. So it can be where they have noticed that their shoulders are off balance, that one shoulder is higher than the other. Sometimes they'll notice that their waistline is no longer the same on the right and the left side. They may notice the ribs in the front are different. Commonly, somebody will see them from the back and they'll notice that their shoulder blades are uneven, or they notice a prominence of the ribs on one side. So we end up seeing these more commonly in the spring and the summer, specifically related to when they go from wearing, very bulky clothing and they go to their bathing suits and their lighter outfits. And then obviously when the kids are being seen by their primary care physicians, and they bend them forward at the waist and they can see the asymmetry of their back. So it's usually a difference between the right and the left side that the people start to notice that something is off with the way that they're standing. And so, when, Brian, what do you, when people do notice this, they notice some asymmetry, what is your recommendation is their next step as far as to where to go
Sure. Well, certainly, uh, you know, seeing asymmetry in your own child can be something that's pretty disconcerting. And when you notice it, I think it makes some sense to try and figure out where this asymmetry is coming from. Generally, pediatricians, this is part of the yearly exam. So this scoliosis is something that most pediatricians are generally screening for and looking for. So pediatricians are a great resource in terms of starting to address some of those questions if you're noticing something. And certainly if there is concern either from the parent, the child, or the pediatrician, evaluation by someone who has experience in treating scoliosis, generally pediatric orthopedic surgeons, might be your next step. When you see either Scott or I in clinic, we are going to be talking to you about what you have noticed, the things that you have seen change over time. Be talking a little bit about your past medical history, if you have any medical problems, or anyone in the family who might have had scoliosis or treatment for a back condition in the past. We're going to do a pretty thorough physical exam looking for some of those asymmetries that we were just mentioning. Doing that forward bend test where you can see some of the rotation that can go along with a curve in the spine. And then depending on what we find and the reason you're coming in, might also get some x-rays of your spine to really be able to evaluate more fully what the spine looks like. And then we can start counseling you appropriately about what the next steps are, if there are any. For most of the patients that come into your clinic, are these patients needing treatment? Are they patients that are being referred by pediatricians? And what's usually the next step for most of these kids?
Well, when they get evaluated by their primary care physician, that's usually the first step for most people. They don't usually make us their first step, but they usually talk, as you mentioned, their primary care physician, and typically somewhere along the line they've gotten an X-ray of their back, and from there they would come in to see us. And so Brian and I are sitting at the end of a funnel, so to speak, is that there are many children out there who have a very mild scoliosis. Brian mentioned the Cob measure, which is a measurement of the X-rays, and that really is how far away from parallel that those two vertebrae are. So the more angled they are relative to each other, the greater the Cob. Most kids that we see are going to have a very low magnitude or mild problem. And it's kind of like a pyramid, that the lower level is, that has a low magnitude to be a lot of kids. And as you get higher and higher numbers, it starts to become fewer and fewer people that are going to have those really significant scoliosis. So most of the kids that we're going to be seeing will be kids that don't need treatment. And if they do, they're going to be lower magnitude deformities, and they may get some non-surgical management for their scoliosis. And a very small number actually get up to the surgical range, not just here in the Midwest, but across the United States and the world. Very small number. So Brian, I'm going to ask you something. You mentioned some of the problems. How is pain a frequent problem with these kids? And do you see it across the whole spectrum of it, from mild, moderate, and severe, or does it present differently?
I think historically we used to think of back pain as predominantly an adult issue, that children shouldn't get back pain. And anytime that a child had back pain, there was some structural cause of that back pain. And I think what we found is that children and adolescents get back pain just like adults do. I'm finding over the last couple of months, as we've started to try to emerge from COVID and after distance learning, that almost all of my patients are coming in with some sort of back complaints. Scoliosis in and of itself, the actual curve, typically isn't painful. But what we know is that back pain is very common, and it may be a little bit more common in children who have a curve. this back pain tends to be pretty similar to the back pain that we all experience at one point or another. And then in particular, what we find is that children who might be a little less active, and we were all a little less active over the last several months, that they tend to have more frequently have some lower back pain. And that pain tends to be when they have to use those muscles of their core and back. So when they're sitting in school for a long time or standing for an extended period, or sometimes with activity, they're experiencing more back pain. And that is not infrequently a reason that kids will go to their pediatrician, get some imaging, and find small curves. And that's one of the reasons that sometimes kids make it to us as well.
Is pain, in your experience, as common in the small curves as it is in the bigger curves?
So I think, at least in my experience, for kind of mild and moderate curves, pain is probably as common in the small curves as the more moderate curves. When I start talking about curves that are a little bit bigger, more surgical range, or very severe, I'm finding more of a majority of those kids are having some back complaints, usually low back pain. Is that something you see as well?
Yeah, absolutely. It seems like the more mild deformities that you described, it's much less frequent. You get to the curves which are the moderate to large or severe curves seems to be a much more frequent complaint, though it's individual specific and probably related to their activity level and the location of the curve too. A lot of times the ones in the very low back on a smaller curve can be much more problematic and uncomfortable than the ones that are higher up in the chest. A lot of times, sometimes the up ones in the chest don't hurt at all, yet they're pretty significant magnitude. So I agree with you, this COVID thing, Brian, that it's been very interesting is that I see this more and more that deconditioning and being inactive has really increased the frequency that we've seen people with back complaints. Whether they've had a mild or moderate curve or they've had surgery, it seems to be pretty universal. And I think that it's really important that the kids get out there and stay active in a safe way, maintaining social distancing. But it's really important that they get out and be active because they're going to, deconditioning is a big part of their symptoms. So.
Everyone coming into clinic the last couple of months has had an increase in their back complaints. Yeah. So hopefully, as we get more
active. Get to the imaging part of this, you mentioned X-rays. When should anybody, as far as MRIs are concerned, where do you see MRIs fitting into the presentation with scoliosis? Is this something that is routine? Is it something that you use intermittently? And when would you use magnetic resonance imaging?
So an MRI, well, take a step back. X-rays are a relatively cheap and quick way of getting a picture of the spine, and it shows us the bones pretty well. But obviously, there's a lot more that goes on in the back than just the bones, and an MRI is another type of way to obtain images of the back that can show us things like the nerves and spinal cord, the muscles around the spine. Now, typically, those things are going to be normal in most children with scoliosis. So typically, MRI is not part of the normal workup for scoliosis, particularly in adolescents. There are a couple of cases, though, where we might consider obtaining an MRI, where there may be other reasons or things associated with the scoliosis that can be, an MRI can be helpful for us to see and to evaluate for these things. Some of those reasons might be children who are a little bit younger when the scoliosis progresses. Typically in my practice, children under 10 who present with scoliosis that needs treatment, I'll obtain an MRI. Children who have curves that just aren't typical. So normally we see curves that go to the right side of the chest and the left side of the lower back. And when those curves are flipped, that might be a reason to think about getting an MRI. Or if we have atypical curves and pain that may not be very typical of kind of the normal muscular pain, And then anyone who may have an abnormal exam, kind of from a neurologic standpoint, might be reasons to evaluate a little bit more fully the spinal cord in particular, and make sure there's not another thing that might be associated with or potentially causing a scoliosis.
Okay.
Do you have
So,
any other
well, no,
reasons
what
why
I'm hearing from you is that a primary evaluation is that MRI is not something that someone should walk into your office with as before you've had a chance to take a look at them.
Yeah, absolutely.
Okay. And the things that we would find on the MRI, most of them are not something that we as orthopedic surgeons would take care of. When they come back positive, which is a minority of the situations, we employ the assistance of our colleagues in pediatric neurosurgery to take a look at that. They're typically things in the spinal column inside the bone that involve the spinal cord. These lots of very long names that just confuse people, but there's things that we look for, but infrequently they actually come back positive. That's the good news. So
when do you start recommending treatment for children with scoliosis? And why do we care? Why do we treat it at all?
Wow, that could occupy a lot more than
a
30-minute conversation. Scoliosis in and of itself, when you look at some of the big studies, doesn't increase the mortality rate in the older kids, but in young kids, that untreated scoliosis can increase mortality rate. And what they've found over the years and multiple studies is that on the younger kids, if they have scoliosis, which is not treated, is that they cause problems with their chest, and then secondarily get underdevelopment of their lungs and the lung volumes. And once that trajectory is negatively impacted by scoliosis, it might not recover, and it might be a permanent problem for the kids. And we know that the lung volumes are we have plenty of a large reserve when we're young, and that infrequently do we use all of our lung volumes from a lot of our activities. But then kids are running around a lot, and they really can challenge that. And the second thing is, as we get older, our chests get stiffer over time, and we actually lose something called vital capacity as we age. So we get to the end of our vertical growth. If we don't have really good lung volumes, it could be a problem for us when we hit our 30s, 40s, 50s, et cetera. So one of the things that we focus on, and Brian does a lot in this area called early onset scoliosis also, we center a lot of our treatment around optimizing the vertical distance of the chest and the low back to optimize the lung development, because that's a really important thing for us. And that is something that 20 years ago was not such a big topic for us to discuss about, but it's become more and more evident that that's a huge part of the overall outcome for these kids. So we spent a lot of time and effort analyzing this and trying to figure out how to maximize the control of the curve, minimizing the curve, and then optimizing the vertical distance that we have in the chest. And that's it for the young kids, but the older kids, we try to minimize the scoliosis impact during the growth with bracing. When they get to that adult age, you'll often hear us talking about the kind of the watershed area of 50 degrees. Most of the larger studies that look at scoliosis in adults, they will say that over 50 degrees, specifically up in the chest, those are curves that can gradually get worse over time. Not as fast as they did, as you mentioned earlier, Brian, about when they go through their pubic growth spurt and they're growing really fast, and then the scoliosis can get worse very quickly. In the adults, it's a very slow process. It's like a glacier moving almost. It's like a 1 degree per year. But if you calculate the overall decades of our lives in 10-year increments, let's just say a 50-degree curve can go every 10 years, 10 degrees worse, 60, 70, 80, 90 degrees. And so that can become a problem. You get a huge deformity that can cause problems with your heart and lungs, but it's usually when you get to say 90 to 100 degrees, does that really happen? And pain is another thing too, which is very common in adults that have scoliosis. So we try to keep the spinal line to maximize lung volume, minimize pain. Obviously, the other thing which goes along with this, which we mentioned earlier about the asymmetry, people and young people don't like asymmetry of their bodies. That's something that is very disconcerting and upsetting to them sometimes, is to see that their waistline is asymmetric, their shoulders are off. So a lot of these things are what we're trying to prevent and deal with during growth and at the end of growth. So when to start treatment, boy, that's a big one in and of itself. You know, I'll tell you my kind of quick philosophy, and then Brian, you can add what you'd like. But to me, somewhere in, you know, we look at young people growing, we have kind of two tiers. We have anything below, say, 20 to 25 degrees of that Cob measure that you alluded to earlier, we typically watch. We get over 20 or 25 degrees, we start employing things like casting for the very young kids or bracing. And those concepts are either to correct or to hold the curve in its current place. You get above 50 degrees, then you start talking more about a surgical approach. Though you could even argue that you and I both watch kids that are at the 60, 65, 70 degree range, sometimes even. But as a general rule, we start thinking about that over 50 degrees.
So I think the decision to start treatment, the factors that are going to predict best whether or not someone is going to have a scoliosis that continues to get worse are how much growth we think that they have left and how big the curve is. So you're thinking about those two factors when you're trying to think about whether or not someone needs or we should start treatment, with the ultimate goal, as Scott was saying, try to prevent that long-term progression that can occur when scoliosis gets severe, 50 degrees being the traditional mark. So I want to get someone through the end of growth with a curve that's less than about 50 degrees, because we think that those patients do just about as well as everybody else with a scoliosis that does not continue to progress or cause too many problems. Now, bracing is for those kids who were worried have a lot of growth left and may get to that 50 degree mark if we just observed. And that 20 to 25 degrees, more often than not, kids with growth are going to continue to progress while they're growing. So that's the group, 20, 25 degrees with a year, more than a year of growth left. And bracing in the adolescent group is really to try to slow down that progression. It's not to cure the scoliosis, it's not to correct the shoulder asymmetry. It's again to try to prevent you from getting to that point where the scoliosis may keep getting worse and cause you problems in adulthood. And then once you get to that point, unfortunately, the only reliable way of preventing that progression for curves more than about 50 degrees is with a surgical procedure in a lot of cases. But as Scott was saying, it's a very small percentage of patients with scoliosis that get to that point. You know, when you're thinking about surgical procedures, how do you approach that? What are we doing? And what would patients expect from that?
Well, you know, it depends upon the age. You know, you and I take care of kids from 0 up to, you know, almost 20 years of age. And so we're taking full care of the full gamut of kids who are growing very quickly, that 0 to 5 group, that group from 5 to 10, which is growing a little bit slower, and then that pubertal growth spurt kid, and even the post-puberty kids. So we take care of kids along a whole spectrum who have different challenges as far as their size and their growth and the type deformity that they have. And so, you know, we have changed a lot over the years, and we just discussed the fact that vertical growth is so important, that those younger kids that Brian mentioned, that, you know, under 10 with the MRIs, and that's really an age group that we try to maximize vertical distance. So we're going to use techniques that are not the old classic fusion techniques. Those are going to be kids in that 10 and under age group that we want to maximize growth. So there's various surgical procedures that are designed to let the kids grow, yet control the spine deformity, correct and control it, to let them continue to get longer and longer distances in their chest and in their spine. So that's really a huge focus for us. That involves, you mentioned the bracing, which is a kind of the first level, casting, and then the surgical area. And some of the classic things that in that are the growing rods that we've used. There's another concept called Schilla in this group, which is a more passive system that we try to grow the kids. So we have a lot of different options for that younger age group, and all centered about the desire to grow the spine. When we get to the older kids, the 10 and older, certainly 12 for sure, that are more mature or at maturity, we start talking about other techniques which are getting there to improve the deformity. And there's been some new advances in this area. Fusion is still the core of the treatment because it is an incredibly successful surgery that we can realign three-dimensionally the spine into a great position, but it makes the spine stiff. There's a couple new technologies which are FDA approved. One of them is called the tether, which it tethers the outside part of the spine and modulates growth to going from curved to gradually getting it straight. There's another device called the ApiFix, which is on the other side, on the concave side, which is like a ratchet. It helps get the spine in better position. Both those are concepts of trying to modulate growth. Both those are very encouraging, but very unsure as to the outcomes. We don't have long-term data on that. So there's a lot of people coming into your office, I know, and to mine, wanting some of these growth modulation surgeries, but their outcomes are still young. And we really have to be careful with who we offer those type of technologies to, because my belief is that if I'm going to do a surgery on someone, I'd rather just do one surgery if I have to do it, and not to do a series of them. And so minimization of surgeries is something that I know I think is a big deal for that. Brian, where do you see the fusions? I mean, the fusions get kind of a bad rap a little bit about, because of the growth modulation things I mentioned that people like to save motion, but how do you see fusions working into our algorithm of treatment right now? And where do you see it kind of going in the near future? Will it go away?
I don't think it's going away in the near future, for sure. I think there's still a lot of questions about these new technologies. They're very promising, but trying to find the right patients for them. And I think our understanding of how the spine grows and how scoliosis develops, we're still working on that and trying to find the right treatment. So I think while a fusion procedure and particularly the types of fusions that we do for scoliosis seem like a very big surgery, and they are. I think the important thing to remember is that most kids who are having these surgeries, most kids that I'm treating in general with mild curves, moderate curves, and bracing fusions, that one of our main goals is to keep you doing everything you want to be doing. Staying active, getting back to sports with a brace, with a fusion surgery is very important. And despite the fact that we are limiting some of the spine motion after necessarily from a fusion, you're losing some spine motion. We still want you to get back to everything you were doing before. Now that's a process after a surgery, and it doesn't happen right away as you're healing. But we do want you to, regardless of how we're treating you, to still do all the things that you were doing before and want to do.
Well, Brian, I think we've come to the end of our little session here. I want to thank you for discussing these interesting topics with us. Both Brian and I spend the majority of our professional practices focusing on scoliosis. And I want to thank you, Brian, for taking some of your time out of your day to talk about this. My last little comment here, that there is a blog that I've been writing. It's called Growing Spine Blog, and it is a place where I write about these topics and that we've talked about today and other ones. And in addition to our website at Washington University, it's a great source of information for people looking for up-to-date information about scoliosis and other pediatric spine conditions. Brian, do you have any closing comments?
Just glad to be able to talk about one of my favorite topics. We could go on for hours about this, but hopefully in 30 minutes we gave you an overview. If there are continued questions, concerns, I encourage anyone to visit with their pediatrician. And of course, we are always available to help out in any way that we can.
I agree. Thank you very much, Brian. And thank you, everyone. And be safe and stay healthy. Thank you very much. Bye-bye.